What's going on, everybody? Welcome to another episode of the Core Consults RX podcast. And tonight, listeners can once again claim ACPE-Accredited continuing education credits by listening to this episode and then going to freeCE.com and taking the post-activity test. And assuming you pass it, obviously, then you will receive your 1 hour credit. So this is going to be a free service for unlimited members of freeCE.com. And, this is completely included in your normal unlimited membership. There's no extra fees or anything like that. And if you are not a member of freeCE, definitely check out their unlimited membership options, because they have all kinds of good stuff on there. Monographs, they have, live talks, they have videos that you can watch, like more lecture style, and of course our podcasts. You can use the code podcast2022 in all caps to get 15% off the price of an unlimited membership for the year. And for today's episode, put in the password itching, ITCHING, in all caps, and that will unlock the post-test for the episode. But again, that is for unlimited members only. You can't purchase it as a single thing or just log in just for the heck of it and get it. You gotta be a member first. So support freeCE.com. They keep us around, and this is 12 episodes we've done now.
Yeah.
So we got a decent library we're starting to build.
I'd say it's decent.
So Cole says it's decent. So there you go. Check it out. See what you think.
My mom, when I was a kid, I would ask her to itch my back or something like that, and she would correct me and say, no, it's scratch your back. And now I've turned into that person who just corrects everybody. Drives my wife nuts.
Yeah, I can imagine.
Yeah.
You haven't even done it. It's driving me nuts.
I know. I guess my mom's to blame.
Yeah, she is.
Right?
Get her on the phone.
Not me.
Let's get her on the phone right now.
Yeah.
Miss Swanson, how could you? My mom corrects my grammar all the time still, too. It's fine. I was good at math.
And then you said, I'm just going to make a podcast where we don't have to use proper grammar.
That's right.
And that's what
There's
we do.
no one that edits this thing.
Yeah. No, not at all.
It's perfect. It's the best thing.
Good. So why is it itching? It's because we're talking about an itchy skin condition today, right?
I think so.
Yeah. So atopic dermatitis.
Yep.
Mm-hmm.
And if you guys are watching the video version, you're like, well, wait, there's more people in the podcast studio. That's because we have two brand new fourth year students with us. Literally their first rotation of their fourth year, working towards their PharmD. Kaleigh, Emilie. Hello, ladies. How are you?
Hi, doing great.
Hello.
They are so excited and not nervous at all to be on the show to talk to you guys today.
Absolutely.
And so they're going to help us kind of discuss atopic dermatitis.
Yeah, they did a lot of prep work.
They did.
It's good.
It's more prep work than I think Cole and I have ever done.
I'm sure.
Ever.
Yeah.
It's a lot. It's impressive. So we're going to kind of go through this, and we'll start off with some background information, kind of talk through a little bit of the pathophysiology, etiology, and whatnot, and then we'll get into the treatment options. There's actually several drugs that have been approved recently.
Whole bunch of new stuff.
For atopic dermatitis. So,
new stuff coming, too.
Yeah.
Yeah.
The guidelines were last written, 2014?
Yeah.
So it's been a minute. They do not reflect all the new drugs that are available. So
I don't know that. Have we done? I think we've done atopic dermatitis, but I don't think we talked about a lot of this stuff.
No, because I don't think they were there when we did it last time. It's been a while.
It's been a while. So
yeah.
So when you think atopic dermatitis, you might be more familiar with the term eczema. There are different types of eczema that aren't atopic dermatitis. I think that's good to note that all eczema is not necessarily atopic dermatitis. There's allergic contact eczema, other types of contact eczema, dyshydrotic eczema, as well as a few other skin conditions. But in general, when you're saying eczema, a lot of the times this is what you're thinking of. It's a disease that can have periods of exacerbations or flare-ups, followed by periods of remission. It presents as skin rashes. They can become crusty and scaly. A lot of you probably have this. It's a very common condition, or you've seen people with it. Common locations for it to occur: inside of the elbows, back of the knees, the face, behind the ears, buttocks, hands, and feet. And a lot of times the medications that we're using for it are supplemented by moisturizers, and as well as maintaining a good humidity in the home, right?
Yep. And what's kind of interesting about this is, it affects a lot of the areas we think about, like Cole just said, but then it actually typically spares like the groin area or the axillary regions under the arm. So that's one way you can kind of work towards your differential diagnosis, because with like plaque psoriasis or something like that, you may not get that same kind of distinction. But typically, atopic dermatitis is going to start kind of early in infancy. However, lots of adults also kind of get diagnosed with it as well. And it's typically associated with elevated levels of immunoglobulin E, so IgE. And it's kind of like this, the term is the atopic march theory, and it's the first disease to sort of present in this series of diseases that all have to do with allergic reactions, so to speak. So, food allergies, asthma, allergic rhinitis, and it kind of progresses, but it starts off with the atopic dermatitis kind of like, leading the parade, if you will. And that ends up leading to these sort of conditions that you often see as comorbidities, and they can play, a factor when we're choosing therapy, for these patients to kind of maintain symptom relief.
Yeah. Sadly, I think we all knew one of those kids who had a lot of allergies like that, and I feel like they were frequently bullied. You ever watch Jimmy Neutron?
I did, yeah, of course.
What was his name? Carl? That's what I always think of when I think of the allergic triad, is like Carl, who had allergies to everything, food allergies and glasses, and always,
I feel like I can't remember
asthma.
Carl. I remember Jimmy Neutron, but I guess I didn't watch it enough.
Carl and Sheen. Yeah, man.
Yeah, that was after my time.
Was it?
Yeah, my younger brother watched it, which you're his age.
Yeah, that's
so that makes sense.
Yeah,
I gotta go back. That's it. That's our homework for tonight.
But yeah, kind of
Neutron.
Kind of an allergic triad-ish thing going on there with the food allergies, the asthma, and then allergic rhinitis. They used to call it triad, but now they include food allergies. So what would that be? What is 4-ad?
Quad.
It's just a quad?
I guess.
No ad?
Quad-ad? I think it's quad.
That sounds like...
Sounds like you're trying to say crawdad.
I was about to say, that sounds like something that would be tasty in a low country broil.
A quad?
A quad-ad?
Quad-ad, yeah, maybe. We're in the low country, folks.
We are. There are some, we'll talk about the pathophysiology a little bit too, but there are some signs and symptoms to look out for. So dry skin, your medical terminology class may call that xerosis. Also thickening of the skin, increase in skin markings, as well as inflammation. All of those will be present. But I think we did want to talk a little bit about patho as well, right?
Yeah. Well, and also too, thinking about kind of the exclusion conditions that we would also have to think about. So scabies is one that can kind of, especially in younger children, can kind of mimic atopic dermatitis at first. Things like contact dermatitis, if it's an actual allergy, all those types of things. So kind of like what Cole was mentioning. And then as far as the actual pathophysiology, it's kind of a
mixed bag?
A mixed bag, yeah, because it's something that I feel like we thought we had a good grasp on, and then now we keep discovering more information, and realize there's a lot of moving parts that kind of end up leading to, the overall disease state.
Which kind of helps them find new targets to attack with some of these new drugs.
Yeah, right? And you can see that with like when you kind of look through these, but it basically, we have this, normally we have a healthy balance between like the subsets of T cells. So like T helper cells 1 or Th2, Th17, 22, and then with the kind of immune dysfunction hypothesis of atopic dermatitis, we think of this kind of imbalance in T cell subsets. And so they think of Th2 being kind of like the predominating imbalance or cause for the imbalance. And so this results in this production of type 2 cytokines. So interleukin 4, interleukin 5, interleukin 13. And those are going to kind of increase the IgE release from plasma cells, which are just activated B lymphocytes. And so from there, we also realized that with chronic, kind of presentation of atopic dermatitis, that Th1 cells also can predominate in certain situations. Th17 can predominate in other situations, and that can kind of lead to other cytokine-mediated responses. And so there's a lot of different moving parts, and you can kind of see now, like we were saying, like the targets of therapy are starting to try to individualize like certain cytokines or certain inflammatory mediators to hopefully control symptoms.
Yeah. Thinking about what some risk factors. So there's a strong genetic component. Mm-hmm. There's some specifics on that. We won't dive too deep into that, but there's a strong genetic component. Infection is something that can cause a flare or even has been associated with like the development of eczema, and it's primarily with Staph aureus. So the skin of patients with atopic dermatitis is almost always colonized by Staph aureus. Clinical infection often causes a flare and has been proposed by acting as a super antigen to be a cause of atopic dermatitis. I think that's pretty interesting.
A super antigen.
I know. It's kind of like when they say super infection. Mm-hmm. It sounds like, which we might talk about that a little bit, but it sounds like, I don't know, a really awesome infection.
Yeah, except it's not great.
It's just like, what does it mean? Infection on top of this thing, just like superimposed on?
Yeah. Well, speaking of super infection, they can also have herpes simplex virus that can lead to a flare-up. And so in that case, they'll refer to it as eczema herpeticum, which is, again, that's where herpes simplex, the actual virus, is leading to the flare. There's also a hygiene component as well. It's one of those things they even say could potentially lead to causing atopic dermatitis in patients, or at least have the initial flare.
And I think that's pretty. What were you gonna say?
I was just say that a lot of times it happens. The hypothesis deals around like childhood exposures to different, whether it's infections or like bacterial endotoxins, things like that, that eventually cause this inflammatory kind of cascade.
Well, and they think that it might be kind of maybe the opposite of what I would think, where it's not so much associated with somebody who's unhygienic, but because of how hygienic we are, they have reduced exposures to some of these things, and somehow that creates a rise in atopic dermatitis. I don't fully understand it, but
I like how you were like, they think kind of the opposite. The experts think way different than I think, which is interesting.
It is counterintuitive.
Yeah, no, for sure. No, it definitely makes sense.
Yeah.
Climate. So, patients who can have flares based on, extreme kind of variations in climate, whether it's hot or cold. Very dry atmosphere, sun exposure can initially kind of improve lesions, but then sweating because of the heat then increases the pruritus, and then you can have other, allergens or things like that can kind of set off that cascade again, and then just kind of spirals back out of control again.
Yeah.
Food antigens, like we mentioned briefly, but that's still kind of like a controversial component of atopic dermatitis. It's not 100% agreed upon as far as the role of food, but it's one of those things that there are going to be providers that will try certain things to try to mitigate certain foods that may cause flare-ups or things like that. But because there's not like a set kind of guideline, it's more so just best guess in some cases, unless there's been like an actual anaphylactic reaction or something.
Right.
If anaphylaxis, you pretty much can bet if you have an anaphylaxis to something, you're probably allergic to that food.
Okay.
Right? Yeah.
I mean,
did you guys learn that in pharmacotherapy?
What do you think? At least 80% sure?
I would say 83%.
83.5%? Yeah.
Yep.
Sounds good. So what did we miss with risk factors and patho, guys?
Anything?
I don't think so. I feel like you hit it all.
We covered
I did. I read one study. I think y'all were talking about. Sorry, kind of.
Emilie doesn't want to talk on the microphone. She's
Sorry
good though.
about
She's gonna do great. Everyone cheer her on. Woo!
So I looked at one study and it was talking about like the frequency of bathing, and I thought that it was interesting that they did. It was in kids, so I'm sure like the kids that didn't have to bathe didn't really mind it, but it was like every other day, I think, and then I think in the same kids, like after so many weeks, they did twice a day, and the kids that bathed twice a day had better like improvement in their eczema.
So they had improvement in their eczema.
Yeah, which was kind of like.
Which goes more towards Mike's hygiene hypothesis.
Yeah.
Yeah, I'm a little confused about the hygiene situation.
I'm pretty sure they're confused too.
I felt like it would kind of like dry it out, like if you like washed more frequently, but I think in both cases like they were followed by like really thick emollients. So
right, yeah, which everybody does right after a shower is slather themselves in really thick emollients, right?
I do, for sure.
My
Aquaphor everywhere.
My son has been sick for like the last 2 weeks, which has been
he?
a pain with daycare. Yeah, he got like a conjunctivitis. I got conjunctivitis, and then it turned into like a double ear infection. So that's what he's got right now.
Heck yeah, perfect.
Only bring that up to say that like when he was a newborn and for the first like 6 months, we did not bathe him regularly. It was like once a week.
Oh, cool. Okay, well.
But he doesn't have any eczema. So.
Yeah, perfect. Look at you.
That goes towards this hygiene hypothesis.
What we said is you will not have eczema, and we were very stern about that. And he learned.
We bathe them more.
We bathe him a little bit more now. We allow him to bathe
at least twice a week.
Cole's a good dad. You can have 2 baths if you're good.
We really need to conserve water.
They're on a budget. All right. So prevalence of atopic dermatitis, about 10 to 12%. It can vary a little bit depending on the reference range you're looking at, but 10 to 12% in children, and then 0.9%, so less than 1% in adults. And it's something that does, again, obviously affects more children, but don't write it off just because the patient's older. And that's, looking at more like the U.S. population. It does affect males a little bit more. Females a little bit more. Excuse me, I said that wrong. And then 95% of cases can occur before the patient's 5 years old. So you get it having to deal with it at a very young age.
And I guess that goes to it being one of the first presentations of that allergic crawdad. Yeah. That word we made up. Yeah.
So you see that coming and you go, oh no, my nose is going to start running. I can't breathe. It's going to be a nightmare.
He's going to have all the things.
All the things.
And itchiness or incessant pruritus is the most debilitating symptom. Children often scratch themselves uncontrollably. And for adults, I'm sure it can be extremely bothersome as well. It may be present in the first few weeks of life, but parents become more aware of the itch as they have the itch scratch cycle where it kind of worsens, and it's the cyclical thing. And usually around 3 months, they notice if that early they're going to have it. But a lot of times, just like we said, it's intermittent with flares and then remissions, and they don't really understand why or when those happen. They're kind of unexplained.
And I actually just see a stat here that says patients who have atopic dermatitis, 30% of them will develop asthma, 35% end up going all the way through that triad and having nasal allergies as well. So 35% end up going and getting all of those issues.
Three.
Yeah. That's
now 4.
Yeah. And as far as allergies go, like peanut allergies, things like that are some of the foods that we think about if you're going to consider foods. And then it says latex and nickel allergy is more common in patients with atopic dermatitis compared to the general population.
Nickel, that is so random.
So I thought so too, except I gave a diabetes talk, I think it was, at some conference, and the guy that went after me was a dermatologist. Mm-hmm. And he came in, the guy was super smart, but he also had 0 presentation. So he just started putting like pictures up on the thing, which actually ended up being really cool, because he'd be like, what's this? Every single thing looked like ringworm to me. That's when I realized I'm the worst dermatologist.
Tinea.
I was, ringworm, every single thing. I'm like, there's no way this can be ringworm every time. And so one of them was like, definitely ringworm this time. This is it. None of them were ringworm, by the way. And
Spoiler.
He would be like, it was on the wrist, and he's like, nope, nickel allergy. You can tell because, and I forget what he said now. I wasn't listening too closely, apparently.
Because it had a buffalo right in the middle.
No. Cole, listen, we're being serious now. No, but it was some kind of jewelry, I guess, had like a nickel residue, and that caused, like, because of like where it is. He said if you see like around the neck or the wrist or ears or something, he said check for nickel allergy. I said,
I guess that makes sense because a lot of jewelry now is nickel free.
Yeah.
Oh, is it? It says nickel free.
Like it'll say it when you buy it.
See, me and Cole only use Cuban links. Pure gold.
I had those aluminum earrings on the other day, and my ears just turned green.
You had aluminum earrings?
No, but isn't that what people say?
I was going to say, dude, you have your ears pierced and I didn't know that. That's going to be hilarious.
I totally have my ears.
I can see it.
I think it's nickel that they worry about.
So that's nickel that's inside of those things?
Yeah.
Mm-hmm. Well, that's good to know.
Yeah, that is good. So buy better jewelry.
I need to buy better jewelry for my wife.
Yes.
Nickel free.
Please don't buy her nickel.
Yeah, if her wedding ring is turning her finger green, you did something wrong.
Problem.
You got ripped off.
Well, we're married, so I did something right.
Yeah. Well, you might not be for long if she finds out.
It's her that made the mistake.
Yeah, she should have checked harder.
Yeah.
Oh, man. Hopefully she doesn't hear this.
She doesn't listen. It's okay.
Oh, good. So clinical presentation, we've already talked about a lot of that. So the physical exam, obviously looking like ulcerative colitis is a huge kind of staple of this, but looking for other changes. So like atypical vascular response, so like facial pallor, delayed Blanch response, ocular or periorbital changes. There could be perioral changes. There could be perifollicular attenuation. And again, it's something that obviously sometimes you're making a clinical decision, and if you're not getting a response, having a dermatologist, come in and actually assess the patient is always going to be a good option if they're not responding to therapy. But because a lot of times this is kind of started in primary care, and then they're sent to derm after that to verify that that's truly what it is.
Right. And not only that, but to grade it in a way, and then probably steer treatment based on the grade. So they have to do a severity assessment with atopic dermatitis, and there are a number of severity scores that can be used. And you'll see these referenced in the clinical trials with these drugs. You'll probably, if you work with these patients, you'll see them referenced in clinician notes and that sort of thing. I'll list a couple of them, but the eczema area and severity index, I've seen in a couple clinical trials, the EASI. Also the SCORAD score, which we'll probably reference a little bit later on, but it's the scoring atopic dermatitis, SCORAD. There's also POEM, which I know that colleagues of mine use very frequently in their practice. That's the patient-oriented eczema measure. It's based solely on subjective patient assessment, and sometimes it can be convenient. But there's also the PO-SCORAD, which is an add-on to the SCORAD, and that's patient-oriented scoring of the SCORAD, which is, again, based solely on subjective patient assessment. Whereas the first two, the EASI and the SCORAD, are objective clinician assessments of the severity score.
And we won't go into the differential diagnosis, but I will say, since I was joking about the ringworm or the tinea infection, one thing to keep in mind is that if the area that you're worried about being, especially, atopic dermatitis is usually going to cause a lot more of a, pronounced area of inflammation and whatnot. But if you have one just smaller area that's just kind of seems to be the only area that's affected, and you just go, hey, it might be dermatitis, I'm going to go ahead and give steroids, and it does turn out to be a tinea infection, not great, because it's going to then kill off your natural bacteria and allow that fungi to just have at it.
Fungi is no fun.
Whoa, no, we did not do
Awful.
that. Yeah, that's for you, TikTok.
I regret that.
Yep. Well, too late. It's going on. Emilie's going to help me edit that later. Go right to TikTok.
I don't know how to work TikTok.
Emilie, you know how to work TikTok. Don't lie to us. Kaleigh, did you know how to work TikTok?
I don't even have
I
TikTok,
can scroll
so I don't know.
through. I don't know how to make one.
Are we all too old for that?
No.
Except for Mike?
Yeah, I'm so young.
I have it.
I'm the
know
youngest
how to watch
one.
them. I don't know how to make one.
Okay.
Yeah.
You know how to watch them. Good.
Yeah,
I'm good at that.
That part, they're great.
Got that down.
Some of them are. Some of them are really stupid, but some of them are really funny. I realize I'm not that funny when I see what people come up with.
I know.
That's the worst.
And not original at all.
Yeah.
Yeah, no, I would spend 100 years trying to come up with something. I'd be like, no, people I'd get 2 likes. It's rough. All right, meds. Want to jump into some meds?
Sure. Did we miss anything before we get into the treatment,
Ladies?
guys?
Kaleigh?
I
feel like you just itching to jump in here, right?
Not yet.
Okay, cool. All right, so the kind of first-line treatment typically is going to be topical options, and we oftentimes will start off with our corticosteroids, our topical corticosteroids. So corticosteroids obviously are going to have the anti-inflammatory properties, antipruritic properties. They also have some vasoconstrictive properties as well, and they're going to decrease the activity of endogenous inflammatory mediators. And they have levels. It's one of the only times I think of when we use the word potency still. If you're not talking about drug development or something, potency, we don't usually use that too often in
That's true.
pharmacotherapy.
I'm trying to think of some class of drugs where we do.
I'm sure there's a couple, but steroids are always the one that I always think of when I'm using it, because it's, like statin intensity. We use things like that. But potency is an actual, definition term that you can use for drug discovery or whatever when you're doing kinetics. But so the higher the potency, obviously, the more the adverse effects. And it's, we're thinking topical, obviously, we're not worried as much about some of the, systemic effects of steroids, which can be all over the place, can affect glucose levels and cortisol levels, obviously. Behavioral, it can cause insomnia. There's so many things that can go wrong with systemic steroids for a period of time. Topical, we cut down on a little bit of that, but it also, can cause pretty significant issues with the place of contact of the skin as well. So it can actually cause like skin atrophy in some patients, which is why like in children we have to use like lower potency because they already have much thinner skin.
Right.
Or certain parts of the body.
Yeah, they get really offended when I make jokes about them.
Who?
Those thin-skinned babies.
Thin-skinned baby? Yeah. They have no sense of humor. It's ridiculous. That's why we got to keep doing it. We got to build. I
make fun of their soft heads, and they just do not think it's funny.
Oh boy. How dare you, Cole? You just made every single mom mad. I'm telling Anna. It can cause increase in acne production, contact dermatitis. It can cause folliculitis, hypopigmentation, and so on and so forth. And you can actually get enough absorption if you're depending on the potency and how long you continue to use those, where you actually can start to get some hypothalamic pituitary adrenal axis suppression. And in some rare cases, I mean, there's you could even get like a Cushing syndrome type situation or that osteonecrosis of the femoral head, cataracts, those type of things that we worry about more so like long term with systemic options. So these 1 pound jars of triamcinolones and stuff that you'll see with 12 refills on them, probably not a great option. Plus, especially when it comes to atopic dermatitis, using them topically, there's actually a tachyphylaxis response too if you do not come on and off of them. So you do want to kind of use them to control the symptoms and then come back off of the steroids if possible.
Right. And not only the age of the person matters with potency, but the location that you're putting it does matter as well. So lower potency corticosteroids you want to use on the face because the skin would be thinner there, or intertriginous areas, which are areas where where skin meets and can kind of rub together. So you want to use lower potency steroids there. Other areas of the body, mid to high range is fine. You want to save the very high potency steroids, which we'll kind of go through which ones are considered high potency, mid, and low. For areas with very thick plaques or that are resistant, like the palms or the soles of the feet. And you also want to limit those to about 2 to 4 weeks of use. But like Mike said, their first line examples of a low potency might be over-the-counter hydrocortisone, like hydrocortisone 1%. A medium potency would be betamethasone valurate, 0.1%. A mid to high potency, like we said, 1 to 2 weeks, and that's usually to rapidly control a flare. They're usually applied twice a day, and after the flare is controlled, you can stop the corticosteroid and just use a moisturizer to maintain until you have another flare.
Now, if you were impressed and you're like, wow, how does Cole know the potency of his steroids like that? One, Cole's very smart, but two, speaking of potency of corticosteroids, we're going to use this as our pearl of the day, thanks to our podcast sponsor, Pearls. He has a great corticosteroid topical potency chart. So it lists all of the different topical corticosteroids from class 1 all the way down to 7, which is the hydrocortisone that Cole was mentioning. And it gives you the generic and brand name of all of these different options so that you never have to wonder. You never have to call Cole and they say, hey, what is this potency? You'll know. So check out pearls.com or the app you can download it. So it's pearls, pyrls.com/CoreConsultRx, and you can get the free version of the app. You get some cool charts and some downloadable PDFs that you can keep. Check it out, and no commitment or anything like that. But they've been supporting us for a while now, so check them out, see what you think. I appreciate it.
Yeah, they even break it down by delivery system.
Yeah.
Lotion, spray, shampoo, foam.
Yep.
So you can never wonder.
You'll never wonder ever again.
No. It's right there.
Yeah, unless you forget how to turn your app on or something. All right.
Or your phone dies.
Yeah, that's the
Bring
worst.
the charger to work, but don't plug it into work computers.
Right. Speaking of vehicles, though, why do we choose some over the others? Because that's the thing that I think some people get confused about, like why we have ointments and creams and all these different vehicles that these steroids come in. So think of ointments as being having the greatest drug penetration of the skin. They're the most occlusive, and so they do enhance that drug penetration. However, they are like kind of a greasy, sort of texture afterwards. It takes a while to kind of dry and really absorb. So these are probably a little bit better used at bedtime, and especially if the patient's rushing out of the house in the morning to go to work or something like that, or school. Creams, lotions do tend to be a little bit more better tolerated during the day because they dry a little quicker. As well as patients who are having really dry skin, sometimes you can use that as almost like a built-in moisturizer. And if there's an area of the body that's being, that's affected that you need to kind of cover effectively without having to, just use gobs of creams and all that, you can use the solutions or the shampoos or foams, the sprays. The problem is the price. Anytime you see anything fancier than like the standard cream ointment, just go ahead and imagine them dollar signs are probably there too. So hopefully over time it's going to come down, but always consider cost, because I think sometimes we get so kind of caught up in the pharmacotherapy, the evidence-based medicine, and we forget that, this stuff costs money.
Right. Like, this is the perfect vehicle for this site and this patient,
and it's $6,000 for
when the other one would be okay. It's just
a little more greasy.
Yeah, and also depending on location, right? So like shampoo, if it's on the head or the scalp or whatever, but I guess the oil and things like that. So it does depend on where it is.
I only use oil on I never use shampoo.
I use oil on my beard.
Do you?
Yeah.
Is that why it stays so crispy and nice?
I get it when I hold my son. The oil gets all over his head and he gets all greasy.
Nice.
So like I have to.
So that's how he bathes.
Yes, how it keeps his hair looking slick.
Nice. That's cool, dude. Oil. That's a good tip.
Yeah,
it's a life hack for
it's
when
not
I
recommended. Then you have to
bathe
bathe him more than once a week if you get his hair all oily. That's the problem.
Okay, I'm writing this stuff down.
There you go.
Mine will be here in like 3 months, so I gotta write this stuff down. I have not read the baby books.
Yeah, I bought at least 3.
Did you? I have bought 0.
Well, I mean,
I'm gonna wing it just like I do this podcast.
I didn't read them, but I bought them.
Don't tell my wife. So what's the steroids though are not working, or the person has a contraindication to them, or maybe like you've been using them for a little bit and you're like, we need to try something else because you are getting some thinning of the skin or some other issues. There are some other topical agents that we can use. There's our calcineurin inhibitors, which have been around for a while now. So we have our tacrolimus, our Protopic, and then the Elidel is the one that came out a little bit more recently, but I think it's generic now, I believe. I could be wrong on that.
Pretty positive.
But for a while there, the Elidel was brand name and it was more expensive. But mechanistically, they're just basically inhibiting the T cell activation. So they're blocking transcription of pro-inflammatory cytokine genes. So things like interleukin-2, interferon gamma, interleukin-4, and you're just kind of shutting down that inflammatory cytokine process. These are also going to be applied twice daily like steroids would be. They are considered to be a little bit less effective than corticosteroids. However, from an irritation standpoint, tend to be a little bit more tolerable. So you tend to think of these as being used or saved for patients who maybe don't want to continue using a steroid in like certain sensitive areas. So you'll see these utilized in like the face or under the arms because they're not going to have the same topical effects.
Right.
However, they do carry a box warning for potential increased risk of skin malignancy and lymphoma. So it's one of those things I think you need to just at least make sure your patient is aware and, keep them in the loop so that they're not going home and happen to Google their medication and go, what in the world?
Right. Benefit risk.
Yeah, definitely having that convo and making sure that they're aware that there is rare risk, but it can happen.
Yep. Elidel is generic.
Good deal. You guessed right.
Nailed it. And we aren't necessarily giving these treatment options in order of preference. Topical steroids are the first line, but we'll kind of talk at the end a little bit about, especially the newer drugs, what might be preferred over some other things. There's another ointment. It's branded as Eucrisa, and it's a crisaborole 2% ointment. It acts as a topical PDE4 phosphodiesterase 4 inhibitor, so it's going to increase intracellular cyclic AMP levels, and that's its mechanism of action. It's a twice daily ointment as well. There can be some application site irritation. There's not really any evidence that it's more effective than corticosteroids, but it is another option that's out there.
It's definitely more pricey than corticosteroids.
Yeah, I don't think it's generic.
No. That's one that I think when it first came out anyway, I remember some derms were writing for it, and some patients were all excited to try the new thing, and then they were like, "Oh wait, it is not cheap."
Yeah, I think that a copay card or something.
Yeah,
I had some patients who used it, but yeah.
And I've heard mixed reviews as far as like actual like anecdotal evidence. I thought it would be a lot more effective based on the cost and everything, but
I think sometimes it gets popped in there in between steroids and maybe some of the other newer stuff on occasion.
Yeah.
There are instances where systemic glucocorticoids can be used in an acute exacerbation of chronic atopic dermatitis. It can be stopped by a short course of systemic glucocorticoids. It's usually a prednisone taper. Like 40 to 60 milligrams for 3 to 4 days, then 20 to 30 milligrams for 3 to 4 days, and that can help shorten a flare.
And I'll mention this just since we were talking about phosphodiesterase 4 inhibitors, but there is an oral version of that called Otezla or apremilast. It is actually indicated for psoriasis, but I have actually seen some people being put on it off-label for atopic dermatitis. And obviously, if the Eucrisa can be efficacious, then this technically could also, we would think could have some benefit. I've also heard very, very mixed reviews as far as how efficacious it is for atopic dermatitis. So don't think of this as being like a go-to option or anything like that. But if you've kind of tried some other options and you have access to this, at least know that there are some off-label use of this sometimes. The big thing with the apremilast, because it is pretty well tolerated. So besides the price, the big issue that people will complain about is the diarrhea that it can induce. And so there's a taper that you have to kind of follow. And so it starts as a 10 milligram dose every morning, and then it's titrated by 10 milligrams until you eventually work your way up to 30 milligrams twice a day. And then that will hopefully mitigate the risk of developing that severe diarrhea. Other GI effects and weight loss tend to be the other complaints that you'll kind of see. Yep.
Thoughts on any of that, guys?
I kind of had a question for the like topical options. I'm assuming we're still doing like some kind of occlusive like lotion or like ointment type situation in addition to that? Do we like sandwich it, or do we like drug then ointment?
So, I mean, I would want the drug to kind of be absorbed
have time,
and have, so I would separate it by a little bit, and maybe, have the person get out of the shower, if you wanted to build like the cleanser, moisturizer on or something like that after a shower, or maybe do the drug earlier and then, shower and then put the moisturizer on right before bed, but separate, because if you put the agent on, if it doesn't dry enough, you put the moisturizer and things like that on top of it, you could potentially
wipe it off
and mess it up.
Also, I mean, I guess the vehicles that they come in can be moisturizing like on their own too. So it probably wouldn't be as important as making sure you get proper use of the medication.
Do we actually name some like hypoallergenic moisturizers and things just to kind of throw some names out there? Did we do that in the beginning?
No, we have not yet.
I didn't think so. Okay, so some hypoallergenic moisturizers, cleansers, things like that. Just for those of you who are recommending patients to go to the pharmacy and pick one up, we have things like Aquaphor, which we've all seen, the Vanacream, which tends to I think be a little bit more pricey, the Eucerin and Sildenafil moisturizing cream, Aveeno lotion is another good brand name. The Dove bar soap that's unscented is available because the fragrances and whatnot can actually induce some of that allergic response as well. So be careful with that. Like Axe body spray is probably out. Yeah.
Sorry, moisturizer?
I
use that as a moisturizer in 7th grade, just all over the place.
Oh yeah, everybody did. You walk into the guy's locker room and like after basketball practice, nothing but Axe body spray.
Also flammable.
Is it?
Oh yeah.
How'd you find that out?
Y'all never did that as like a flamethrower?
No, we used WD-40 for that.
Oh. WD-40?
Mm-hmm. Really? I think it was that. And just because it has the little
straw
thing.
It has a nice stream.
Yeah. I got grounded for like a week.
Not recommended, kids. Listen.
No, definitely not. My dad grounded me for a week, and it's terrible.
Definitely don't spray the Axe body spray on your arm and light it on fire so it can burn off your arm hair.
Also, don't
do that.
Don't use Axe body spray at all because that is a terrible decision and sets you up for failure in life.
Yeah.
So, there you go.
Yeah, we see what happened to me.
This episode is brought to you by Axe. Oh, could you imagine if they heard this?
They got shampoos too.
Yeah, that's ridiculous.
Body wash.
And they have that stupid.
Those kind of smell good. Not gonna lie. Yeah, I could do without the body spray, but like
they have the
body
detailer like brush thing. It's like, oh, it's got multiple sides. I'm like, okay, Axe, let's calm down just a little bit. So yeah, there's a bunch of different options available. So whatever one's on sale and the patient likes is good.
Good. There's also immunosuppressants that we use in other disease states that can be used as well. I believe especially in like a flare type situation, right? Cyclosporin has proven to be effective in atopic dermatitis, and then second line options there would be methotrexate, azathioprine, mycophenolate, but we know that there are side effects associated with these, so be aware of that, of course.
Yeah, I think we tend to think of those as like potential long-term, maybe almost like controller medications if we've tried other things to kind of combat the flare-ups.
Okay.
This is thinking along the line, and not cyclosporin, but the others that you mentioned, the methotrexate and the azathioprine, almost like you would with like a Crohn's or ulcerative colitis, like when it's in remission,
just to settle,
just to kind of
response.
and keep it from
suppressed.
flaring back up again.
Right.
But one of the new kids on the block after the guidelines were written, not anymore. It's not new anymore. So if this is new to you, we gotta fix that.
We gotta have a talk.
We gotta have a talk.
You obviously didn't listen to our last episode.
Yeah,
this one was at least included.
Definitely,
in the last one.
was on there.
Yeah.
And our asthma episode. So what are you doing? Dupixent is the brand name. It is an interleukin 4 receptor blocker, and it also has blocking interleukin 13 as well. And so it is something that kind of targets the main sort of inflammatory mediators that we think about with that initial, kind of imbalance of those T cell subtypes. And it's a sub-Q injection that you do every other week. The cost is it's a little pricey. I believe it's still over a little over $1,000 a month for the injections, but it does have very easy to use auto injector and adverse effects besides the injection site reactions. Obviously, does increase the risk of conjunctivitis, blepharitis, and then eye pruritus and dry eyes as well. Now, I will say for this, because we were talking about kind of like the responses and the disease comorbidity sort of like escalating, patients who have asthma as a result of this, when they are trying to get a prior authorization approved for a patient to get on Dupixent, if they do have asthma, especially if they are, because one of the indications for this to add to a patient's asthma regimen is if they're on oral corticosteroids to control their asthma. So I had a patient actually 2 weeks ago that was taking 5 milligrams of prednisone every day for months. And they had really bad asthma that was uncontrolled, plus they had atopic dermatitis that was flared up. And so because to get them off of the steroids for both asthma and atopic dermatitis, the oral steroids, Dupixent is a very good option in that respect. And that was more on the asthma studies that kind of showed that. But if you look at the GINA guidelines for asthma treatment, they mention, like having a eosinophil count that's elevated, or if the patient requires oral corticosteroids as being like a kind of a reason to go towards Dupixent when you're dealing with like phenotypic asthma presentation. Right. So that's a good kind of kill two birds with one stone, so to speak. And it also is a very good tool to get it approved by the insurance. If you have that, I've done this 4 or 5 times now, and I haven't had anybody, any of them reject it when they see the comorbidities, especially if they're steroids, because they do not want people on steroids.
For patients, even for atopic dermatitis alone, for patients who have tried other things, Dupixent is pretty readily approved with prior authorizations, and maybe an appeal, but it's pretty readily approved these days, even though it's pricey.
And Cole will appeal.
I will appeal.
Yeah.
I will appeal twice.
I'll play it. I will keep applying until you approve my crap.
It will happen. You'll get a long fax. Lots of pages of
all the studies. Do you do that too?
Oh, yeah.
I McDonald's them with information.
I don't always do that because it actually does kind of gum up the process if they have a million papers to look at. But like if I'm trying to be annoying, I'm just like really
you guys
annoyed.
are going to deny this. Cool. Okay, here's 47 studies.
I'm not just going to give you the PubMed ID. I'm going to just copy the whole 45-page document. You're going to get it all.
I've done the same thing.
And then
it's hilarious.
Then you print it all out. Don't save that as a PDF. Print every one.
And I go, you read every page of it until you approve my drug.
You legally have to.
I'm going to watch you. I want you to FaceTime me while you do it so I can make sure you do it. For those of you who don't have to deal with prior authorizations, other than just putting in to cover my meds so that the doctor's office can take care of it, good for you.
You know who doesn't?
Who?
Well, we have the people. We have like around here. We have a naval base and a Air Force base. And since they have like their TRICARE formulary, they don't have to deal with PAs and stuff. It's like if it's on the formulary, you get it, and it's no charge.
That's cool.
What if it's not?
Then you don't get it.
You don't get it.
Yeah.
Sorry. Thanks for your service.
Do it.
Yes, you could, but you couldn't get it at one of those pharmacies. Yeah, you have to go outside.
Yeah, I think the copays are pretty high too if it's a non-preferred brand name or something.
It depends. Yeah. But So Dupixent would take care of two of those.
Support the troops. Is what
two of those 4 crawdads. Like, I guess a biad.
We're going to have people saying that by accident, and now people are going to be like responsible for a bunch of people.
Funny thing, there is an actual term for it. It's probably like, I don't know because it's a triad because it's like a triangle.
Uh-huh.
What is it? What is 4? It's a cube. I don't know.
A quad. I still say it's a quad. Like, is it not?
Am I crazy? End in something more than quad?
I don't think so.
I don't know. I just think
like
of
a
like
quadplex. How about that? That sounds cool.
That sounds cool.
I feel like that's something.
I know it's wrong, but it sounds cool.
What? That is.
I'll Google.
Yeah, please.
All right, y'all figure this out.
Yeah, please. That's top of the line right now.
So one of the again the newer class of medications that we're seeing for atopic dermatitis, and we have new ones kind of on the horizon and that have recently been approved, are the Janus kinase inhibitors, or the JAK inhibitors, as they are colloquially referred to. What does that mean? It's basically prompts a messaging system to recruit more cytokines, and so if we're blocking that, we're going to reduce the amount of cytokines that are drawn to the area. There is a topical version. It's a Opzelura cream, ruxolitinib, I believe is how the generic name is pronounced. It was approved less than a year ago, September 2021, specifically for short-term treatment of mild to moderate atopic dermatitis. The patients have to be immunocompetent. They also have to be over 12 years old. And it's only studied, like I said, for short-term, 8 weeks at a time. We don't have long-term data. Primary side effect is just irritation at the application site. Otherwise, it's pretty well tolerated. But there is a box warning related to infections, potentially.
Every type of infection you could ever imagine.
Every serious infection you can imagine.
And lymphomas, just for good measure.
And lymphomas, yes. So lymphomas, tuberculosis, fungal and viral, and bacterial infections. Though this is the topical version, most of that data in that box warning is related to the oral JAK inhibitors of note.
And I will say, because I tend to, as soon as I see the JAK inhibitors, I tend to go, ugh, because like for rheumatoid conditions, things like that. However, there is a very good antipyretic response with these. So for atopic dermatitis specifically, it may be worth some of
trash.
It's definitely not trash.
Not trash.
It might be semi-trash. We don't know yet, but the jury's still out. But it's definitely not as much trash as it is for with some of the other conditions like psoriasis, for example, or even rheumatoid conditions where we're thinking TNF-alpha inhibitors and whatnot.
I think people in the space are actually reasonably excited about them.
Yeah, I mean, it's definitely, they're putting a lot of energy in developing these.
Yeah, so
it's got to be something to it.
Got to be something to it.
They didn't check with us first.
No.
So
why wouldn't they want our opinion, though?
Dude, that's what I'm saying.
I tell you what. There's another new one that was approved more recently in December 2021. It's similar in mechanism to Dupixent. It's Adbry is the brand name, tralokinumab. It only blocks IL-13, though. It's an IL-13 antagonist. Similar to Dupixent, it's a sub-Q injection every 2 weeks. Approved for moderate to severe atopic dermatitis in December 2021. It was studied as monotherapy, but also in combo with kind of mid-potency corticosteroids. I can't remember if we mentioned the side effects of Dupixent, but some eye issues like conjunctivitis is one, and that also kind of carries over with Adbry. So it was with Adbry in the studies, it was 2 to 3-fold more common in patients receiving it than placebo. As far as its efficacy, I mean, it was only put up against corticosteroids and was more or less non-inferior, superior, but it wasn't, of course, put up against Dupixent. So at this point, I don't think anybody's recommending it over Dupixent, but it's just kind of another interleukin antagonist option, I suppose.
Did you all have anything on that one specifically, or any of the studies or anything? Did they compare it anything to topical agents or anything that you guys saw? Anything worth mentioning at least? And if not, it's okay. I'm just wondering.
No, I didn't see anything comparing topicals.
Kaleigh, anything for you?
No, the only things that I saw were being compared were Dupixent to 2 of the newer drugs that we haven't talked about yet.
Mm-hmm.
But those are not topical.
Okay. So yeah, apparently it's the interleukin 13 pathway that's dealing with this conjunctivitis risk.
So interesting, huh?
Yeah, I actually did. I was looking at a quick search, but it's something about neutralizing IL-13 associated with lower conjunctivitis risk than having the dual anti-leukin 4 and 13 blockade. Apparently, it's some other study from October 2021. That's as deep as I went in it. 3 sentences.
Well, that's pretty good.
So yeah.
Better than I
I'm
went.
going to probably save this and read that later because that's kind of interesting. because conjunctivitis, when I was like, probably just an accident.
Yeah.
Turns out, no.
No, it's legit.
Interleukin 3 and 4, they go right for the eyes.
Yeah, that's what I do in the fights I've never had.
Yeah.
Just go right for the eyes.
For sure. It's a good move.
All right,
what's our newer drugs? So our oral agents, and these have been around for a little bit for like other conditions and whatnot. But for atopic dermatitis, in fact, this one, the abrocitinib is an oral JAK inhibitor, and it was approved in just January 2022 for atopic dermatitis
right.
specifically. Because I think it was rheumatoid last year.
Yes.
So they did, like, for example, the JADE Compare trial, where they compared the 100 milligrams and 200 milligrams of the abrocitinib versus the Dupixent versus placebo. And it seemed to have a little bit better response with the JAK inhibitor compared to Dupixent, and definitely better than placebo. Kaleigh, you looked at that study too. Is that what you were kind of gathering from the results of that? That was the JADE Compare?
Yeah, that was the JADE Compare.
And it was the higher dose, right? That was the one that it was better. Like, the cost and the risk then becomes a big issue because Dupixent's also super expensive. My big thing is these studies tend to be a little bit, short as far as the duration. So with the oral JAK inhibitors is where all those
that's where we
box
want to know
warnings
how safe it is. Yeah.
And now we have all these new warnings being put out there about cardiovascular risk and thrombosis and all these different things.
Cancer.
Yeah, and so it's like it's with the oral agents, from like Xeljanz and some of those other older agents, and so it's one of those things to me. It really, I guess it would just depend on if they're not having them. I still would try to lean towards Dupixent myself, I think. And just until we have more data to see exactly where that risk is.
Yeah, well, it was interesting because the trial was 16 weeks, and that's when it ended. And we know atopic dermatitis is a chronic condition, so I think more research needs to be done before a decision is made here. But you were right. The 200 milligram dose was superior, but the 100 milligram dose was also statistically significant.
It was statistically significant?
I think so, yeah.
Okay. I thought, okay.
But the 200 one was even better.
Okay.
Yeah, I guess in general for the flare, that's probably where they get that 16-week thing from, but they're going to have multiple flares. So they're going to have to use it multiple times.
Well, and then you have to make that decision of, okay, you've got control of the flare. Are you coming off of the medication now? Because a lot of patients are going to keep using it.
They're going to want to keep taking it, yeah.
So that's a tough one.
In that meta-analysis I was talking about before we started this, it's from 2019, so I don't know like how updated it is. But and that was before it was approved for like atopic dermatitis. But it was saying that the JAK inhibitors consistently demonstrated higher efficacy than like Dupixent and baricitinib too. I don't think we talked about that one. But there was no meaningful statistical differences in safety-related outcomes as like in this little meta-analysis that they did.
Comparing it to Dupixent.
Yeah, the JAK inhibitors to Dupixent and baricitinib.
But did it mention risk? Did you? I didn't hear that part. Okay. So that's my big thing is, one, it's most likely going to be used longer, and then two, I just feel like we need, especially since the warning about the cardiovascular risk, I feel like just got put on late last year, October maybe, and so they make me a little nervous. Not that I work in the space on a day-to-day basis, so I probably shouldn't even have an opinion, but that's okay.
Well, what do we do except for give opinions about things we don't work directly with?
Oh, that's
every
true.
Episode,
this whole podcast.
Yeah,
made a good run doing that. But no, it's definitely something that I'm curious to see how it all plays out because, like Cole said, it's something that is a target that's really been like, I feel like there's a lot in the pipeline and everything else for it, so it's gonna be interesting. If we find out that we have all these new drugs and then every one of them increases risk of CV events, that's going to not be great.
I know. Especially, some of these diseases that they're treating, not to discount atopic dermatitis, very uncomfortable disease, but not necessarily life-threatening, right? So what's your cost benefit for possible stroke, heart attack, cancer versus, additional treatment compared to what you were getting with the previous treatments, you know what I mean?
Yep. I don't want it. Not about it.
Yeah, but people are on them.
Yeah, for sure.
Somebody made that cost benefit analysis and said yes.
Yeah, somebody did. Maybe it might not have been them.
True.
You can also use some adjunctive therapies as well, so like antihistamines orally, just to help with the pruritus. So you'll see hydroxyzine tends to be a pretty strong first-generation antihistamine. It's also very sedating, so using it in this regard, you also got to make sure that patients are aware that it's going to cause some sedation as well as the anticholinergic effects, because it does.
You think it's more effective than the non-sedatings for this purpose?
For me,
anecdotally, people seem to say yes, but
yeah,
I don't know if that makes sense.
So the active metabolite of hydroxyzine is cetirizine, but it just doesn't have as much blood-brain barrier crossing. So, and this is completely my opinion, off-label thing. I would actually think that the cetirizine twice a day to control the pruritus would be a little bit better option than hydroxyzine 3 times a day. It may not be as quick of an onset, but I think over the course of a couple of days, it would help control the pruritus. And I feel like I've actually seen a dermatologist actually write for that, but I could be making that up.
It still is a pretty quick onset. But
yeah,
yes, definitely that's Mike's off-label talk with the twice a day cetirizine.
So it's fine. I'm throwing it out there.
But I think that it's. Well, I probably referenced this when we recently talked about antihistamines. I can't remember when that was.
Allergic rhinitis, the last episode.
Oh, was it the last one?
Yeah. Time flies when you're having fun.
Time flies. Is because they're getting that CNS effect and they're feeling something, then they're going to say, oh, yeah, this one is more effective than the non-sedating one, when maybe it's not affecting their itching as much. It's just they feel this thing happening. So they're like, I felt that. It was good. It's working. But, doesn't necessarily have to do with their itching.
I take
Can you itch while you sleep? Yes, you can.
You can.
No.
Can you itch or can you
scratch
while
you itch? Yes. Okay. Thank you.
Miss Swanson,
Thank you.
She literally had her hand on the phone ready to dial us. Saved it. Anything else with this? Anything? Any of the other meds we haven't talked about or experimental meds we got? We're running out of time, but anything?
Yeah. What did we miss, y'all?
Did you want to talk about Rinvoq?
Yeah.
You want me to talk about Rinvoq?
Of course. Go for it.
So it's also a JAK1 selective inhibitor used for moderate to severe refractory atopic dermatitis whose disease is not adequately controlled. So there's the Heads Up trial comparing that to Dupixent. Same kind of outcomes that we looked at with the Jade Compare trial. Same primary and secondary endpoints, and it also demonstrated superior efficacy versus Dupixent in patients with moderate to severe atopic dermatitis, and it had no new safety concerns as well. Obviously, except for that black box warning.
Until that massive warning came out after that. So it was September 2021 when that came out.
So possibly better efficacy than Dupixent, but along with the concerns that we have with the oral JAK.
Exactly, yeah.
It was also compared to Sabinco. So which one's that? Abrocitinib.
Mm-hmm.
And it said it demonstrated more achievement in the eczema, one of the scoring things that we were talking about earlier, the eczema area and severity index after 16 weeks. It had better results than the Sabinco group.
There you go.
Yeah.
But I mean, a lot of people developed acne, so I don't know if you would prefer acne to eczema.
I guess
it depends on
I got rid of my eczema. However, I am riddled with acne now.
Yeah, so I mean, that was like a big common adverse effect.
I feel like then you're going to treat the acne and you're just going to cause a whole nother cascade of.
Yeah.
That's just.
It's like, here's your isotretinoin.
Yeah.
Oh my gosh, could you imagine?
I know.
Yeah. You definitely be getting
the severe dryness from the isotretinoin causes eczema on your
face.
Your
eczema worse.
It's a vicious cycle.
It's a cycle.
And now you're stuck with both.
Yeah. Oh no. Could you imagine? You have both now? This is terrible. I can't believe I hate this podcast. It's for educational purposes only, not to be taken literally. Okay.
Yeah, don't take us literally.
No, take us literally if you're listening for education purposes, not patients. There you go. That's what I meant.
There you go.
I'm not a lawyer, guys.
Just play one on a podcast.
Just play one on a podcast. I think we're about out of time, so I hope that was kind of a helpful overview. If you do have any questions or comments, concerns, anything like that, our emails will be in the show notes on whatever podcast streaming platform you're listening to. You can also reach us on any of the social media platforms under Core Consult RX. If you want to reach us on LinkedIn, we have a cool page for that now. You can even text us directly if my phone would hurry up. It's 415-943-6116. Send a text, and it will give you an automatic response at first. and you don't have to respond to that if you don't want to, but I'll get back to you as quick as I can. Also, if you like more of the traditional lecture styles, what I like to call the boring stuff, check out our Patreon, because we basically do traditional lecture style PowerPoints, video lectures that I've created for my PA students, and we've been getting feedback. There's some pretty good pharmacotherapy reviews. So
I think there's some fantastic stuff on there.
oh, thanks.
For the price.
For the price? $3 a month.
Yeah.
And you could go on there and steal all 4,000 slides or whatever I have on there now, and then just unsubscribe for $3. You could rip all my material off and start your own PA program.
It's high quality stuff. You would pay a lot more elsewhere for that amount of
pay
information.
3 times that much
At least.
So yeah, check that out if you're really bored. But yeah, that helps us support the show as well, and buy some cool equipment so we can hopefully bring you guys good quality stuff. So it's not like doesn't sound like we're talking tin can. And if it does, sorry, we're trying. Thank you guys so much. Thank you, ladies, for coming on the podcast.
Absolutely.
Y'all wish them good luck on their adventures as P4s.
Please.
Just think, in 11 more months, you'll be done.
Oh my God.
That sounds so much worse than in 8 more rotations.
No, 11 months.
Great.
All right, y'all. Have a great night. Bye.